Good morning, everybody. And I would like to first of all thank Olivia for inviting me here today. I'm sure most of you know IGenics. We are the lab that does the testing. This is the lab most of the academic friends of ours do not like or do not appreciate. We never get acknowledged by them. But for the patients, thank you all for supporting us, and we believe in supporting you. That's our goal, to help you get better. And we play our part in helping you diagnose the disease. And we've been doing this for more than 20 years. And in the last 20 years, when the first tests were developed, a lot more research has happened, and we have found a lot more new information. And at IGenics, our goal is to keep up with this information and come up with better diagnostic tests that can help patients. Over the last 2 days, we've been hearing that there are no good tests. And I would like to challenge everybody who has been saying that there are good tests. If you go out and look, we have come a long way from where we were. We have methods that will detect early disease, active disease, and late disease. And that's what I'm going to talk about, is what we have done and where we are in the diagnostic field. Disclosures: I'm the president and the lab director for IGenics, and I get my salary from IGenics. I'm also vice president of research at ID Fish Technology. I don't get any compensation from them, but they are the ones who help us develop some of the reagents that we use at IGenics. And I have stocks in both companies. We all heard over the last 2 days that tick-borne diseases are spreading. So what we wanted to see is, what are we finding in our patients? We have heard stories that you can have multiple infections. The question I ask is, if you had 5 or 6 of these diseases, would you be walking today? The answer is most likely no. Therefore, it is important that you get the right test with the labs who have test validated properly. So what we did was, first of all, we look at tick populations. What do we find in it? Most of our ticks that we have looked at come from patients who have found them either on themselves or their pets. And as you can see here, Borrelia burgdorferi, in the ticks we tested, 10% were positive for Borrelia. The Borrelia Miyamoto story is not from our data, because we were not testing for them till recently. Came from the study that was done and reported by Dr. Cameron. And they are showing that 2.7% of the ticks are infected with Borrelia Miyamoto. Babesia in our studies we found was 4.7%, Ehrlichia 4.4%, Rickettsia 4.3%. However, one of the things you notice here is Bartonella. We did not find Bartonella in the ticks we tested. We have tested over thousands of ticks, and there are only 2 cases where we have found ticks to be positive. We do not know whether this came from something that was already on the patient or on their pets. So in our hands, we really haven't found Bartonella to be transmitted by ticks. So the next question was, what are we finding in our patients? Pathogens we found highest in our population was Babesia. 37.3% had Babesia. And you've been hearing that Babesia is on the rise. The next one was Borrelia burgdorferi. You all know about that. But not what we found, which is very interesting, and nobody else is thinking about it: tick-borne relapsing fever. 27.7% of patients had tick-borne relapsing fever antibodies. Bartonella was fairly high, about 20% had Bartonella antibodies, Anaplasma 16.7%, Rickettsia 12.8%, and Ehrlichia 6.9%. When we look at co-infections, almost 40% of the patients had at least more than one co-infection. 15% had 2 co-infections, 3 co-infections goes down to about 4.6%, 4 infections, practically less than 1%. These are very sick patients. If we look at the tick-borne disease, they are spreading. It shows all the different diseases that we have been monitoring with our data sets. Lyme, Babesia is on the increase, relapsing fever, as you can see, Bartonella. The least one was rickettsia. Maybe we don't get that to be tested on most patients, and Ehrlichia, those were the lower ones. Lyme disease is the most prevalent. I'm not going to go through any of that. We know that the test we have currently will pick up the mid stage of the disease. Most tests will pick that up. The problem is early disease and late disease that is being missed. And really, in the population we see here, most of them, really the late disease is the problem. What we have done at iGenix is to develop a battery of tests that will cover the full spectrum of disease. When you look at tick-borne diseases, it doesn't matter what disease you are looking at. There's 2 ways of looking at it. One is to look at the immune response of the patient to that pathogen. And the second one is to look for the pathogen itself. It could be by culture, it could be looking for DNA or pieces of proteins. In case of Borrelia or in case of tick-borne diseases, it's very difficult to culture. So we are left with PCR or looking for antigens as a direct test, and really the indirect tests are the most useful ones or the most sensitive ones that we are finding to date. I'm going to skip some of these. The problem, most labs and the FDA clear test only use one species of Borrelia to develop their tests. And that is the reason we have been hearing for the last 2 days the tests are insensitive. Over the last 20 years, we have learned that there are multiple different strains and species of Borrelia burgdorferi that cause disease. In addition to that, people travel. So whether if you're living on the East Coast, you could be going to the West Coast and picking it up, or to Europe, to Asia, Australia, Africa. You don't know where you picked that bug up. You want a test that detects your infection. And that is what we have done at iGenix, and I'm going to share that with you. This is the 2-tier test. I'm not even going to go into that. We all know that the sensitivity is a problem. Recently, FDA cleared a 2-tier ELISA test. Now, this test, even though the data looks good here, the problem I see is that if your first-tier test, ELISA, is 75% sensitive, you come in with a second ELISA, you'll improve the specificity, no doubt, but your sensitivity is going to be no better than the 2-tier test. So we are still missing all the cases we were missing when we had the 2-tier ELISA followed by Western blot test. So it really doesn't answer the question that we have here. So what have we developed? Lyme immunoblots. What are those? Okay, so if you look at it, Western blots, we need cultures. Cultures vary the way they are grown, and to grow and maintain cultures is not easy. So even if you develop different Western blots for all the species, there's going to be too much variability, a high cost associated with developing that, reading them, and you still will have problems with specificity, because when you make a Western blot, you are separating antigens by size, proteins by size. There are thousands of proteins in a bacteria. When you separate them, there's going to be multiple proteins at certain positions. So it's not a clean blot, and that is why we had issues with cross-reactivity with viruses, other spirochetes, other tick-borne diseases. But with an immunoblot, you decide what you want to put on that. So we use recombinant antigens. These are pure antigens at specific positions. So when you look at band-end, you know that this is what it is. If it gives a reaction and you see a signal, you know it's there. What we are doing is we have not changed the reading criteria for immunoblots. We still read early stage, late stage antigens on that. The difference is we now can put antigens from multiple species of Borrelia burgdorferi, and that is exactly what we have done. We have put antigens from 8 different species. And what have we shown? This is our study where we took some very well qualified samples, and here we show you the sensitivity of the Lyme immunoblot. 98% sensitivity with well characterized samples, specificity of 96.7%. One test will answer those questions, and we do IgM and IgG. Now, it's equivalent to slightly lower than the 2-tier specificity. However, the sensitivity is far more superior than anything we have to date. And these tests are approved in New York State as well. So we can offer this to anybody in US and anywhere. If we looked at over 1,000 patients where we had tested them by our Lyme Western blot, which is made from 2 species only. And when we tested the same samples with immunoblot, you can see the positivity rate definitely went up. And the reason is we started detecting species that we were not detecting with our Western blot because we had 2 species. For example, Borrelia californiensis, Borrelia bissetti, Borrelia mayoni, Borrelia andersonii, americana. These are the species that are causing the disease in US. We were not picking most of them. And when we look at the data, almost 50% of the patients would be missed if we only had a test with B31 and 297. We have done that calculation, and that's where the number is coming. We have looked at over 1,000 patients to come up with those numbers. Clearly, this is the test you have to do if you're doing a test. Do not do Western blots. Go straight for immunoblots. One immunoblot will give you the answers. Now, some patients do not make antibodies. Secondly, it takes a while before antibodies come up. What do you do? So we always suggest doing a panel approach where we suggest doing PCR and immunoblots. And this is a study that we looked at where there were 250, this is recent, 294 patients that were tested by our Lyme multiplex PCR, which is very, very sensitive, and Lyme immunoblots. We read them by CDC criteria, and you can see that 53%, 18% were positive, 12.9% by PCR, overall 27.9%. With the IGenics criteria, with the immunoblot, we had a sensitivity of 48%. If we added PCR, which remains 12.9%, overall, the sensitivity improved to 54.4% in this group of patients, clearly demonstrating that using a panel approach increases sensitivity of detection without compromising specificity, because the specificity of both these tests is extremely high. So if we look at the disease, very early in the disease, the first response is T-cell response when you get infected with any pathogen. And therefore, very early in the disease, T-cell would be useful. PCR would be useful when you see it at the site of the bite. But if you did blood PCR, it's not going to be positive in the first week or so because the Borrelia are still in the skin. Later on, your PCR in blood will become positive. Slowly, T-cell will remain positive for a while till your immune response comes out with antibodies. Then you'll see IgM coming up, IgM converting to IgG, and in some patients, IgM can persist for years. We have seen that. And then IgG goes up and goes down. We see in patients where we see full-blown response. In others, we'll see few antibodies showing up. IgM converts to IgG, but you don't see the full-blown response. And therefore, the tests that we recommend are very simple. We recommend T-cell tests early in the disease or very late in the disease, or in patients who don't make good antibodies. Immunoblots are the most sensitive in our hands throughout the disease, and PCR. That's all we have for Lyme in terms of diagnosis at this point. And I'm not going to go into details about the IgX spot. It's a T-cell test that looks for reaction to specific Lyme antigens, and you detect it. Going to the co-infections, tick-borne relapsing fever. This is, the disease looks like Lyme, behaves like Lyme, but is not Lyme. What is it? It's tick-borne relapsing fever Borrelia. All of us here thought that tick-borne relapsing fever was easy to diagnose. It wasn't very common here. You could diagnose it because you get fevers. When you get infected, relapses and fevers at set intervals. But that is not what we are seeing in most of our patients. What we are seeing is Lyme-like symptoms. Most people don't even remember having the fevers. We talked to the physicians of about 200 patients. None of them remembered having flu-like symptoms, is what was written in their symptoms. And when they were negative for Lyme, and we started testing them for tick-borne relapsing fever, when we were doing the study, they started coming back positive. And when we started sharing this data with the physicians, they said their patients were getting better, and they would send emails saying, can you test this patient for us on this, because this patient is negative. That's how we did our studies. And as you know, there are multiple species of Borrelia that can, in this group. This disease has been known for a very long time. 1913 was the first case. And during World War, louse-borne relapsing fever, millions of people died from that. So it's an old disease. Even in US, as early as 1939, cases were being reported. But we haven't done much with that. Now we know that it's present in 49 of the 50 states. The most common species we find is Borrelia miyamotoi, which most of you have heard about, Borrelia hermsii, Borrelia turricate, and Borrelia parkeri. Most tests or most physicians are only looking for B. miyamotoi because this was discovered to be found in hard ticks. So it coexists in patients, is co-transmitted in patients by the hard ticks. Sordis scapularis and pacificus, both of them will transmit that, but there are other species being transmitted by the hard ticks which we don't even know of. I think Borrelia johnsoni probably falls in that group, but I am not sure, the data we have suggests that it may fall in there, but there's no full evidence on that at this point. Again, I just want to show you what we found. And the immunoblots, I'm not going to go into great depth about immunoblots. They are made in the same way as our Lyme immunoblots. They detect multiple species of tick-borne relapsing fever. All the common species in US, Europe, and Australia have been detected by our blots. All I want to point out that it's important to test for tick-borne relapsing fever. If we look at our Lyme immunoblots, in a study, this is on over 1,000 patients, 15% of the patients were positive for tick-borne relapsing fever and 8% for IgGs. So about, I think 15% overall, yeah. So the point is that there are patients that have mixed infection, Lyme and TBRF, patients who are Lyme infected with Lyme Borrelia only, and there are patients infected with tick-borne relapsing fever Borrelia, and the symptoms are the same. You can have Lyme disease caused by both of these groups of Borrelia, and I think this is very important take-home message. So please include tick-borne relapsing immunoblots and PCR in your differential diagnosis to look for tick-borne relapsing fever. These tests, tick-borne relapsing fever test immunoblots, are now even approved in New York State. So these, again, are available everywhere now. Moving on to co-infections, babesiosis, the second most, or one of the most growing disease in US. We find it everywhere. I want to point out that most people talk about Babesia microti only. We have shown, and we have solid data showing that Babesia duncani exists everywhere. We have found ticks on the East Coast that are positive for duncani. Our first tick came from Connecticut, where we found duncani positive in a tick. But what we didn't do was we did not speciate the tick. We know the ticks are carrying it because these are ticks we are getting from patients from these regions. So one has to remember, irrespective of where you are, you need to look for both Microti and Duncani. There has been a variant described in Missouri. We haven't looked at that at this point, but we will start looking at that now. We can get a culture of it to work with, and that's going to make it easy. Second development that has taken place in case of Babesia is now it's possible to culture Babesia duncani. Yale University Professor Ben Mamoun, his lab has been able to culture Babesia duncani, and that is going to allow us to develop some new tests. They've done a lot of work on that, and hopefully, in the next year you'll hear more about improvement in diagnosis for Babesia. So again, we have direct and indirect test. We have a fish test that I'm going to talk about, which has been very, very useful. It's a test that is developed at a genus level. And we did it purposely, develop it at a genus level, because when we first started out, we didn't know what was out there that was causing the disease. We knew about Microti and Duncani. And the test really looks at patients who have active infection. So basically what happens is it's like you make a blood smear when you're looking for parasites. And then you stain it with a very, very specific RNA probe, detects ribosomal RNA. So when you look under the microscope, if you have the infection, the parasites will fluoresce. So it's easy to see them, and it's very specific. And using this test, we were able to identify Duncani and Microti in patients. So what we do is when we get a positive sample, when we are validating or trying to do some studies, we'll take a fish positive sample, PCR amplify, and see what are we finding. To date, we have found both Microti and Duncani. We have found Microti in US and in Europe and in Australia, and we have found Duncani also in US, Europe now, and in Australia. So this disease that we have looked for, we haven't looked for divergences yet, but these diseases are worldwide. We have cases from Africa where a person has not traveled anywhere, and Asia also. They thought it was malaria. The first case that came to us from India, they thought it was malaria. When we looked at it, it had very high antibodies to Babesia duncani. We couldn't do anything further because we didn't have a blood sample to go and do PCR on that. But that came last year, very high levels. The reason they sent it to us, because malaria was negative on that patient, had all the symptoms. These are some pictures that we see taken under a microscope of the different species this test detects. This data, hopefully by next year, would be all published. A patient sample showing you Babesia microti. This is one of our earlier patients where we were able to show the patient had Babesia microti. Babesia duncani smear here. And what do we find? Again, we looked at data to see what our tests were finding. We looked at the percentage positives in this study where we looked at 186 samples. 51% were positive by FISH and IFA. By FISH only 13%, and these would be very active cases. FISH looks for RNA, it's looking for live organisms. Unlike PCR, which will look at live and dead organisms. FISH just looks at live organisms. IFA is when IgM is positive, its active infection converts to IgG. By that time, you are not going to be able to detect any of the parasites in blood. You'll just see antibody levels. So early in the disease, FISH is very good, followed by IgM, IgG. That's what we have, and that's what we recommend. So if we look at total samples, was 105 that were positive, 81 were negative in this study by using a panel approach. So in conclusion, Babesia IFA detects all stages of the disease, except the very early stage where you haven't even made antibodies. When we go to Babesia FISH, it will detect early infection. Patients who don't make antibodies, Babesia FISH would be very good. We find that Babesia FISH is far more, in our hands, is very sensitive, better than even PCR. And we detect, and I've shown you that we detect all three species, Microti, Duncani, and divergence by our FISH assay. And the PCR we have will detect Babesia at the genus level, and then we speciate to Microtium duncani. So all our tests are really designed as much as possible to look at the full spectrum of the disease, not just one species. Bartonella, again, we have heard Bartonella is everywhere, and maybe we don't know why we are getting it, but we strongly believe that you may be getting it from your pets as well. They carry Bartonella. This disease has been known since 1871. Bartonella bacilliformans, the most serious cause of disease. And this was known in 1971 in Peru, in South America. We don't see that many cases of them. And as time has gone on, as you can see here, we have found new species of Bartonella. Most of this work has been done by Dr. Bransfield and his team in North Carolina. They have really provided the information on Bartonella. We didn't know much. And I'll tell you what happened. When we first developed the fish test for Bartonella, this was early 2004. Fish was positive, and it was a new test. We were always concerned when we bring a new test on board, how specific is this test? You know, this is new. It's useful. So we go sequence anything that's positive, and we can get PCR and sequencing out of it. And at that time, we had found several species of Bartonella in the patients. All we knew at the time was Bartonella henselae and Quintana causes the disease. We didn't know about other species, so we just put it aside. We didn't even know what to do with it. There was no way we could develop a test that would even be able to identify except the fish test. And we knew it wasn't the most sensitive. It was a great test when we could detect it, but wasn't the most sensitive test. So it's a very useful test, gave us a lot of insight as to what's going on. It's still very useful in patients. And with that knowledge, we were finally able to, I'm just going to skip some of these and go straight to, this is fish showing you the sensitivity and specificity of that, real patient samples where we see Bartonella in patients. We developed a multi-species Western blot. So what we've done is we are able to culture 4 species of Bartonella to a level that we can make Western blots. It's Bartonella henselae that we all know about, Bartonella quintana, Vinceni, and Bartonella elizabethae. Now, you probably haven't heard much about Vinceni. We are finding Vinceni to be very prevalent in our patient population. Elizabethae as well. I mean, of course, we find henselae and Quintana, but Vinceni seems to be quite high in our population, patient population. This is probably transmitted by dogs who have pets, because there have been reported cases where dogs are known to carry Borrelia vinceni. Whether it's the dogs transmitting it or the fleas that are on them or whatever is on them is transmitting the disease, we don't know. That needs to be worked out as yet, but we are getting it, and this is an important disease that we need to think about because it affects our children. Children, we have heard stories, I mean, these are true stories, where is an A grade student suddenly drops and is almost to C grades. Why? Kids have pets. They play with them, they don't know. And this is the symptom, it's affecting the brain. And when they get treated, they are getting better. Once they get better, they get back to their normal life. So it's an important disease to look for. We don't have all the answers at this point. This is a test we developed for a couple of years and introduced it last year. We don't have that much history as we have on other tests, but this is turning out to be very useful because it's doing 2 things. We are detecting Bartonella at the genus level because we have genus level antigens. We have identified them, characterized them, we know that, and we have species level antigens, so we can speciate as well. And therefore, you get 2 sets of results on this. We give out the species, or we say genus positive, and you'll see that on the results. This test is very important. Hopefully, we'll be able to add more information next year on this and develop an immunoblot on that. This is just to give you an example, because this is what we did. We compared it to our IFA test. It only looks for one species. But when we went to the Western blot panel, which includes 4 Western blots, our sensitivity improved dramatically, almost 4x, as you can see, 4 to 6x. So this test is working very well. It's very specific. If you look at the blots, you don't see multiple bands on them. You see few bands, but very specific, and it differentiates. So, right now, most labs will give you tests for Hensley and Quintana. Of course, there's one lab, Galaxy, who has been a pioneer in this field and has shown that they detect all the species. Now, this test, the advantage of this test is you do not need multiple samples. The sample you send to us for your immunoblots is good enough. If you wanted to add on a test for this, you can do so, because we keep samples for 2 months. You do not need a second row or a third row for this test. All the tests that we do, you do not need a second or a third row. 1 row is enough for all the tests. And we have a similar IG export which looks for T cells for Bartonella. Now, just to show you what we are finding, with the fish, we had 11.5% positivity rate. Western blot, of course, is the highest. IG export, IgX is IG export, that looks for T cells. We had 17.7% positive. In Bartonella, we are finding T cell to be positive. Again, this is at the genus level, and overall, 53.1% were positive in this group of patients. These are patients who have symptoms of Bartonella that were sent to us. It's not just random samples. Ehrlichia anaplasma, again, very simple. We only do 2 tests for them. We look for antibodies, and we run PCR on them. In case of Ehrlichias, we are finding PCRs to be sensitive in some cases, but if you had to choose a test and you had to do only 1 test, go for the IFA. It's pretty sensitive. Recommended test panels, we always recommend the borreliosis panel because it includes Lyme and TBRF, and as I've shown you, it's very important to look for tick-borne relapsing fever. For the co-infections, either fish and IFA. If you really had to choose 1 test which will give you the most information, go for the IFA test. Because I understand, there are constraints, financial constraints, that will hinder everybody doing every possible test. And you can always talk to us, and we'll try to guide you and say, start with this. If you need more, go to the next level, if that's the case. And with that, I would like to thank everybody for listening.